So, ladies and gentlemen, it's my pleasure to present this talk on personalized glycemic control. My name is Charles Preiser. I'm working in the Erasmus University Hospital in Brussels, and I would like to present this talk also on behalf of my friend Jamie Crinsley from Stanford Hospital in Connecticut in the US. We have a few potential conflicts of interest to declare in relation with this talk. So personalized medicine, and especially personalized glycemic control, is a reflection of the common sense thought or belief that one size does not fit all. No, in terms of glycemia, what can we define as normal glycemia or euglycemia or normal glycemia? In the field of diabetology, 8 to 110 milligram per deciliter is considered as the normal value in fasting conditions. What about critically ill patients? These patients are under metabolic stress. They are fed and not fasting, hopefully, and they got some treatment that can by themselves increase blood glucose. And what about critically ill patients with chronic hyperglycemia or patients with type 1 or type 2 diabetes? The usual J curve is like this, and this will be, we'll keep this picture in mind for this talk. On the x-axis, you got the blood glucose, and on the y-axis, the worsening outcome. There is a J curve with the lowest value being associated with the best outcome. In normal conditions, in healthy volunteers, this will be 80 to 110 milligram per deciliter. But in patients with chronic hyperglycemia, such as poorly controlled diabetes, there will be a right and downward shift of this J curve. This was already shown a few years ago by Michael Kosibarot in patients with acute myocardial infarction. This team just showed that the continuous line was the patient without diabetes, and the dotted line, the patients with diabetes. And as you can see, there is a shift to the right and to the bottom of the J curve, linking mean blood glucose to, in this case, in hospital mortality on more than 16,000 patients. When we reviewed this with ditermezoten, and we pulled data from studies in children and in adults, we also found the same shift to the right and the downward shift of this J curve in patients according to the presence of chronic hyperglycemia, the blue line, or no chronic hyperglycemia, the red line. Even in Leuven, where the intensive insulin therapy was shown as a life-saving therapy, this effect, this benefit in terms of survival, was not observed in patients with pre-existing diabetes. So there is something different in diabetic patient and patient with chronic hyperglycemia as opposed to patients without chronic hyperglycemia. It's probably related to the intracellular adaptive mechanisms that the cells develop to overcome or to neutralize the toxicity of high glucose, including the end glycation products and other intracellular pathways that are activated by the chronic concentration, by the chronic high glucose concentrations into the cytosol. Now, at bedside, how can we know whether a patient has a chronic hyperglycemia or not? The answer is quite easy and has been largely validated by our colleagues, the diabetologists. So you can use the A1C, the glycated hemoglobin, drawn at admission, and you can calculate using the Nathan's equation, which is a very easy one. You can easily find it on the web, even on this website of the American Diabetes Association, and you can easily calculate the estimated average blood glucose within the last 3 months when you use the A1C levels. And this was indeed clearly demonstrated and validated. When we looked in the department in Erasmus at the outcome of patients, the ICU mortality, and we looked at the glycemic ratio, which is the calculation of the admission blood glucose divided by the average blood glucose estimated from the A1C, we got also a nice U-shaped curve with the patient having the blood glucose at admission closest to the usual value, the estimated average value, had the lowest mortality as opposed to those who were below or over the usual blood glucose value. It was also confirmed by an Australian team of endocrinologists. Here, the outcome is the admission in ICU, so the percentage of critical illness. They also found that the same stress hyperglycemia ratio, so the blood glucose divided by the estimated average glucose, was also related to the outcome, the outcome being the rate of admission in the ICU. Now, in terms of relation between hypoglycemia and poor outcome, there is also a nice data set from more than 10,000 patients published in 2016, showing that indeed when the A1C was higher than 8%, so poorly controlled diabetes patients, poorly controlled patients with diabetes, there was a higher mortality in this adjusted analysis, higher mortality in patients who got hypoglycemia than in patients with a normal glycated hemoglobin. Just highlighting the difference in the relation between the dysglycemia or derangements in blood glucose according to the presence of chronic hyperglycemia. With Jamie Crinsley, we looked at the data set of 5,567 patients admitted in his center in the States from 2011 to 2019. This was just accepted in critical care medicine, so we'll be able to read the paper soon. The first finding we got is that indeed the mean blood glucose was higher at admission in patients who got a high A1C, higher than 8%. The coefficient of variation or variability calculated over the first 24 hours was also higher in those patients with a high A1C as opposed to the patients with a normal A1C. And likewise, the rate of hypoglycemia was also higher in those patients with a high A1C as opposed to those with a normal A1C. So the behavior in terms of glycemia is different according to the A1C. Now, when we look at the relation with the mortality, this is really impressive. So look at this. The first three columns are the patients with a A1C below 6.5. The middle ones are those with a patient with a A1C between 6.5 and 7.9. And the right bars are those with A1C higher than 8%. The blue bars are the patients with an admission blood glucose of 80 to 140, the green bar 140 to 180, and the red bar, the patients with an admission blood glucose of higher than 180. And you can see that the relationship between the blood glucose at admission and the mortality, which is on the y-axis, is completely opposed according to the A1C measured on a sample drawn at admission. So the patient with the highest blood glucose, average blood glucose level, had the lowest mortality if they were hyperglycemic at admission, as opposed to the patients with normal A1C. So this completely changes the picture. We also looked at the relationship between the hypoglycemia and coefficient of variation in the same paper, and we found that, in fact, hypoglycemia was associated with a higher mortality in contrast to the previous study on a large set of patients, but the multicentric ones. So we got a higher mortality in a patient with hypoglycemia if the A1C was lower, 6.5 or 7.9. And likewise, for the coefficient of variation, we got also higher mortality, a higher likelihood of dying in those patients with a coefficient of variation of 15 to 30 or more than 30, so a high variability in those patients with the lowest A1C. So again, the interaction of acute and chronic hyperglycemia played a role in the relationship, the association between hyperglycemia, and glycemic variability to mortality in the critically ill. This is translated in the clinical practice. They changed the target, the blood glucose target, and they found that indeed they got some improvement in mortality when they tolerated a higher blood glucose level in those patients with a high A1C. So in brain injured patients, we know that the J curve can also be drawn in those patients with a right and upwards shift, meaning that the hypoglycemia is really the worst that you can do in a patient with brain injury. Hypoglycemia is very deleterious for the brain because it is the obligatory fuel. There are no cerebral stores of glucose, and the transporters into neurons and astrocytes are very sensitive to changes in the glucose concentration in the cerebrospinal fluid. We know that the hypoglycemia is associated with energy crisis and long-term neurocognitive dysfunctions in children. So hypoglycemia should be avoided in any case in patients with brain injury. Many questions and hypotheses to be answered. Maybe continuous glucose monitoring associated with closed-loop systems to regulate and to tighten blood glucose is the solution. It's a continuing story. Thank you for your attention.